Hello and welcome to today's edition of We Talk Health. I'm Dr. Mike Revelle, the Medical Director of the Emergency Department here at Jackson-Madison County General Hospital, and with me today is Dr. Fielding Randolph, Hospitalist for West Tennessee Healthcare. So welcome, Fielding.
Thank you.
So how long have you been a hospitalist?
I've been a hospitalist here at Jackson General for 7 years.
7 years, that's a long time. So probably lots of folks out there wondering, well, what is a hospitalist?
Well, a hospitalist, the first time it was mentioned was in the New England Journal of Medicine in 1996. Our program here is not quite that old. It's been 16 years in the making. It is a program where you have a primary care physician in the community that takes care of your routine outpatient work, and then when you get sick and need to come to the hospital, somebody has to take care of you at the hospital. It's becoming more of a recognized specialty over time. They're actually looking to make it a board certification at some time, but you only take care of people in the hospital, and when you complete their care, you transition them back to their primary care physician, and that allows the primary care physicians to spend more time in the clinic and spend more time with their patients. So it's just another smaller specialization of medicine. Right.
So the community needs to recognize that the doctor they see at home may not be the doctor or even their partners taking care of them in the hospital.
That's correct. And we're a tertiary care center, so we take care of patients from all over West Tennessee. So with that, a lot of these smaller towns, you wouldn't be seeing your regular doctor anyway. So we take the place of everybody's PCP, whether they're in Jackson or whether they're in Union City or Martin or anywhere.
Right, and I know that the benefit of having you guys is there's somebody in the hospital at all times. In the old days, your primary care doctor would come around in the morning and then maybe around in the evening, and tests would get ordered at those two different times. But you guys are here 24/7.
We have 24/7 coverage. We have at least 10 people here during the day. That number's going up as the hospital grows more and more. We have at least 1.5 here every night. It's going to go up to 2 or 3 at night every night. But we do have somebody here 24/7 in case anything happens with any patient in the hospital, so that we can be there to provide them care immediately and not have to wait till the next morning.
Right, exactly. You can respond and actually go see the patient right then. You don't have to drop what you're seeing in the clinic to leave and come over or whatnot. So it's West Tennessee Healthcare, in my mind, adopted early the hospitalist idea and started their program here, like you said, 16. Has it been 16 years ago?
It's been a full 16 years when Peter Benez and I think Pam Murray were the first two. They're both still working with us. We don't have a high turnover rate here, so a lot of the faces that you see have been here quite some time.
Excellent.
The hospitalist is generally either family medicine board certified or internal medicine board certified, and it just depends. We have about half and half at this point. So they go to medical school like every other doctor. They go to residency, and it'll either be in family medicine or internal medicine, and that's where their training is. And then after they get out of residency, then they pick a job that leaves them in the hospital alone instead of working in a clinic or in a dual setting, which is becoming more rare, where somebody actually works in the clinic and in the hospital at the same time.
Right, and you have folks, I know where you say you're here 24/7. It's not the same doctor that's here 24/7. You mentioned that there are lots of different doctors, and just because if you come in at midnight, the doctor that takes care of you from midnight to 7 a.m. is probably not going to be the doctor. Well, it's not going to be the doctor that takes care of you during the week, but hopefully you'll have that same doctor for your stay here unless it's a prolonged stay.
And that is one of the issues that people don't like about hospitalists is they don't see the same person over and over again. But we can't be here 24/7, so we have somebody that admits them at night, and then when they get the next morning, they get assigned to another hospitalist, and that person, we try to keep them with the same person their entire hospitalization. Now, if you have a really long hospitalization, you may see 2 or 3 of them, but if you're only here the usual stay, which is somewhere about 3 days or so, generally you'll have 1 hospitalist, maybe 2 at the time, and then you'll go home back to your regular doctor. But we try to accommodate that as best we can, because we know it is a concern of people in the community that they'll be passed around as an item instead of as a person or a patient. We want to make sure that they realize they are patients and we're taking care of them on a personal level.
Right, and I know you and I are both on what they call the Medical Executive Committee here at the hospital, and we're always looking for ways to improve communication between providers, especially the hospitalist and their primary care provider. And I know there's some rules coming down the pipeline about getting those discharge summaries and basically what happened while you were here in the hospital to their providers. So
yeah, we've always done it. We have in our group, we provide the primary care provider with a discharge summary. We have a secretary who does it the next day, every day. So if the discharge summary isn't ready at that point, we send them the history and physical, which is the initial paperwork when you come to the hospital. and the last day's progress note, which is the last note. Usually the discharge summary will be ready, and the primary care physicians will get that immediately. Now Medicare is changing that to where they're going to mandate that you have it done within 48 hours, and that's going forward. But we're trying to do that because we want your regular doctor to know what happened to you in the hospital. So when you go back and see them, and most of the time it's 1 to 2 weeks after you leave here, that they have the paperwork in front of them to know what happened, that you were here, and what they need to do going forward. Because a lot of times there's 1 or 2 tests that need to be followed up upon after you leave the hospital. So when you come to the hospital and you're in the ER, the ER physician, like Dr. Revelle here, makes a decision that somebody needs to be in the hospital. So then they call a hospitalist and maybe a specialist too, depending on what your problem is. And then we come down and see you in the ER, and we write all your orders, introduce ourselves, write all your orders, help you get transitioned upstairs. And then we start taking care of the inpatient aspect of that, taking care of you while you're in the hospital. And so we work very closely with the ER to get the process started.
Yeah, and you guys are much like we are in the ER. You have to know a whole lot about a whole lot of things, and certainly wind up admitting primarily most patients that come to the hospital. So even if Grandma falls and breaks her hip, even though her primary problem is a broken bone or an orthopedic issue, 90% of the time or more, you guys admit. Same way with cardiac patients and other patients.
Well, Grandma that broke her hip almost always has some other medical problem and is on very complex medications, and so we admit and take care of that. The orthopedic surgeon, of course, will take care of the hip, and then we deal with all the medical issues that come along the way. We carry a census of 250 patients on day on average. When I first started, it was about 175 to 200. Now it's to 250. Our biggest day, we've had 306 patients on service. That was last winter, and it's about to be wintertime again, so we'll probably have another 300-day census.
Right, and that's divided over 10 or 12 physicians, so you're looking at
least 10 at the current moment. We're going to try to get up to 12. We're trying to get our patient to physician ratio down to where we have less patients per physician, so that we can have more personal interaction with them.
Right. I know a question I get sometimes in the ER is, when will the doctor be around to see me or my family member? And that's hard to say. You guys start with the sickest patients first when you're around. So you typically, and correct me if I'm wrong, but go to the ICU and then see some of the sicker patients. Obviously, patients that can be discharged take priority, I think, because you've got to make room for more patients turnover. And then to the other patients. So it's difficult to tell somebody, when they'll be seen, because not that they're any less important than the sickest patient, but at the same time, if I have 20 patients to see and I spend 15, 20, 30 minutes with each patient, it's going to take me a while during the day to get to everyone.
Yeah, but if you've got a list of patients you've been seeing for 3 or 4 days, it's amazing how quickly you can tell somebody what time you're going to be there. Because they're on the 6th floor and you start on the 9th floor, and then by the time you say, okay, I'm usually on the 6th floor by 11 o'clock in the morning, and somehow you can come up with that after 3 or 4 days of doing it. You can't tell them on Monday or Tuesday, but by Wednesday or Thursday, usually you can.
Right. But coming from the ER, it'd be difficult.
Coming from the ER, you wouldn't, because it could get divided up to any hospitalist in the morning, and everybody's a different creature of habit, so people do things slightly differently, and it may fall under a different schedule.
Right, but to reiterate again, the benefits of having a hospitalist as opposed to the way we used to do things are, the hospitalist is here 24/7. So when that test results come back and you either A, need another test, or B, may not need any more testing and could potentially go home that day or the next day, that decision can be made right away and not delayed until 5 o'clock rounds or the next morning rounds.
Mm-hmm. That's correct. I mean, we can respond to things more quickly and not have to wait any time period to do it. And also, if there's a patient that's deteriorating for whatever reason, we can have a physician lay eyes on them within 5 or 10 minutes. You don't have to wait an hour for somebody to drive from clinic. They can be there immediately.
Right, and communication, I think, among the specialists and the consultants is better because you're both here in-house seeing patients, and if you have an issue, you can talk to them face-to-face, which I know happens a lot that the public doesn't always see with us behind the scenes talking about patient care and what the best decision needs to be made for certain patients.
But also, if you have a specialist that's in clinic and the hospitalist can actually go lay eyes on the patient, then you can have a physician calling the specialist, another physician, and say, this is what I'm seeing, and it helps direct their care a little bit more. Even if the specialist can't get back to the hospital at that moment, you've got physicians here all the time that are laying eyes on patients when they need to be and are available.
Billy, one of the things that patients sometimes wonder is which hospitalists do. We have a couple of groups of hospitalists here, and you guys kind of go to the community docs and select which primary care physicians you're going to admit for, and tell us a little bit how that works.
We have agreements with several different primary care groups here in the community and in some of the outlying counties. Over time, we've established relationships with these counties, and we've come to agreements that when their patients come to the hospital, that we'll admit their patients. There are other hospitals. I'm a Jackson General or West Tennessee Healthcare employed hospitalist. There's another group. Jackson Clinic has a hospitalist group, and then there's the UT Family Practice has a group that they admit for as well. And they have their own agreements with various things. Obviously, Jackson Clinic will have an agreement with themselves, and they may have one or two other clinics they admit for. But if you're in your primary care's office and they say, hey, I'm sending you to the hospital, then you can ask them. They know who they have the agreement with, and they can tell you what group to expect to admit you when they get to the hospital. Also, we get phone calls from the primary care physicians in the community all the time from their clinic saying, hey, I'm going to send this patient to the hospital. Can we get them direct admitted or do they need to go to the ER? And it just depends on what's going on with the patient. If they're really sick, we need to send them to the emergency room. If they're a little bit more stable, maybe we can send them directly to the floor. And we have a system for that, and we get phone calls all day about that.
Right. Obviously, our emergency departments, not just here at West Tennessee Healthcare, but throughout the country are crowded. And if you can direct admit someone, that's great. But as you said, that's sometimes without laying eyes or having labs or studies back immediately. It's best for them to start in the ER and then go upstairs when you guys decide that needs to happen. And if you see a primary care provider, nurse practitioner, physician assistant, whatever, that doesn't have an agreement with a hospitalist, you may want to encourage them to do that, because otherwise you get put what we call in the unassigned pool, which means that somebody's going to take care of you, but it may not be the same group every time, or it may not be the same provider or whatnot. So nothing wrong necessarily with our unassigned call system, but it would be good for you to check with your primary care provider to make sure you have a hospitalist on their panel.
And again, we do send them when you leave. We send all the information to their to the primary care's office so that they have the record of the hospitalization, so they know you were here when you come in.
And then the only difference, I guess, would be if they don't have a regular medical doctor, it becomes a little more difficult at discharge to try to find them someone. I know you guys work closely with case management and other things. Maybe if they have an insurance that they just haven't set up a primary provider that helps them decide what panel they go to, et cetera, et cetera. That's
correct. And there is somebody in West Tennessee. I mean, if you can't get in with, if you don't have coverage or something, there are health departments that can help you out. There's all kind, and we admit for a lot of the health departments in the community as well. I mean, there are people that can get you, for which we can get you follow-up appointments if you need to have a particular lab test drawn, or maybe we're waiting on a result that won't be back for 5 or 6 days, and there's no reason to stay in the hospital. You can leave and then follow up with them to get the result instead of having to sit in the hospital for 5 days.
And then lastly, but certainly not least, just because you come to the ER and you're not feeling well doesn't mean you need to be put in the hospital. That's probably a topic for a whole nother We Talk Health is who meets hospital criteria, but just wanted to briefly mention that. I know that's some confusion out there that, it's just not just because you don't feel well or you feel weak or whatever is a reason to be admitted to the hospital and figure that out.
And we are, with everything we do, we're obligated to Medicare and making sure that we follow guidelines and that we provide appropriate care and that we don't provide care that's unnecessary or don't keep you in the hospital too long.
Right. Most insurances have adopted those Medicare guidelines and say that if you have this, or this, then you need to be admitted to the hospital for this reason and for this many days, typically. Mm-hmm. If you have an elderly patient with pneumonia, there's typically so many days allowed in the hospital, barring any complications, that you can be admitted for.
And those are guidelines and averages. And so, there will be a couple people that leave a day or two early and a couple people that stay a day or two longer. But, we don't just look at the days and say, your days are up, get out of here. We keep you till you're well and you get to go home. And like I said, some people will be ahead of the curve, some people are behind. And it just depends on how well you're doing. But we do strive to keep our patients getting the right amount of care and not be in the hospital too long, because that leads to a new set of complications.
Exactly. Well, Fielding, thanks so much for coming in today and talking with us about what a hospitalist is and what a hospitalist does. And I appreciate your time, and thanks for tuning in to this episode of We Talk Health.